On to our absolutely fabulous opening keynote speaker. I am so honored and really excited to hear Dr. Phillip Coffin, who is from UCSF. You have his information, I think, on if you go onto your, you can find all the bios of everybody online if you go to your QR codes, but I will just give you just a tiny bit of a highlight of what he has done and what he's doing. He's a board certified and practicing internist and an infectious disease specialist and addiction medicine specialist. He directs the Center on Substance Use and Health at San Francisco Department of Public Health, including clinical trials, assessing medications for multiple substance use disorders, and interventions for opioid safety, overdose prevention, and related infectious diseases. I've had the opportunity to hear him speak several times. And the reason that he is here today is because he has fabulous, really, really important information for you about methamphetamine, about fentanyl, about the toxicity that we all need to be aware of and the overlap of those two. So I will welcome Dr. Phil Coffin to the stage. Please thank him for coming here. He is a very busy guy. And we're hoping that he will take the time to be able to answer some questions too. So thank you so much, Dr. Coffin.
Thank you.
Thank you.
And do I use this microphone as well as I'm mic'd? So I think this goes elsewhere. I'll give that to you. All right. I am so excited to be here. It's so fun to be in person. I love the in-person stuff. I will be honest, I have a family. I also love not having to travel at times. But it's so nice to actually be in person. And I was told this morning that the topics of my talks can be a bit morbid, which you may, I wasn't named for that, but anyway, actually when I decided to go into medicine, I used to be back on the East Coast, I went by Phil. When I decided to go into medicine, you may understand why I extended it to Phillip. And I'm going to go further down that rabbit hole. I actually have a brother named Barry. So let's get another joke in there. So since I can't sing, but I can tell good dad jokes. So I'll tell you a joke that hopefully doesn't apply to any of us. What is the difference between ignorance and apathy? I don't know and I don't care. All right, I don't have any disclosures today. And there's some additional slides in here, which I'll give you a moment for while we go through. Don't want to jump through everything too quick. And what I'm gonna try to do today is give a sense of the epidemiology of and sort of the clinical characteristics, et cetera, of fentanyl and methamphetamine toxicity. I'm gonna focus a little bit, you'll hear my focus a little bit more on methamphetamine because I think we already know a lot about fentanyl, but there's not a lot on methamphetamine. I think that's kind of a black hole for a lot of us. And then talk about potential approaches. My hope is that you're gonna walk out of here, if you don't already have it, some of you probably already do, but that you're going to walk out of here with a little bit of a sense of sort of how to think about methamphetamine toxicity, because it's not the same way that we think about opioid toxicity. So we'll start out with a little bit on the epidemiology. Sorry, this is jumping. There we go. So emergency department visits by drug class. So the black line there is opioids. So we know that's been going up and up and up and up, and we've got a giant disaster. The other lines, so there's the solid gray line is cocaine. And then the dashed line is psychostimulants, which is CDCEs for methamphetamine. It's essentially all methamphetamine. And that's been going up really since 2009. And those lines down bottom are independent of opioids. And then if we look at mortality, on the left of the screen, you can see really that fentanyl jump that really started 2014 and has just gone blindingly through the roof in the national crisis that we have. On the right, you can see cocaine and methamphetamine, i.e. psychostimulants. And what you see there is this increase. For cocaine, you see that things were really flat until fentanyl came along, and then they started jumping up. For methamphetamine, things were really low through the early 2000s, et cetera. And then they started going up. And then with fentanyl, they went up more steeply. And when we look at fentanyl, we see really a high prevalence of other drugs involved in the overdose death. In most areas, so about 40% didn't have stimulants or other opioids involved. So that's a little higher than I'd expect. I'd expect it actually to be less, and I'll show you some San Francisco data. But the most common things also involved in fentanyl deaths are stimulants. So, and that nationally is accounting for about half of the deaths. It's not new that stimulants are involved in opioid deaths. This has been going on for a long time. This is some work I did actually in New York City in the 90s. I'm dating myself. Who's more fun to date? And in those data, half of the opioid deaths also involved cocaine, and half of the cocaine deaths also involved opioids. So this isn't new. We've known for a long time that that deaths are more likely to occur among people who are also using among people who are using heroin. Overdoses and deaths are more likely to occur among people using stimulants, and that there's just a lot of overlap between those two categories. There's a lot of co-use of stimulants and opioids. It's not totally new, but I do think it's a little bit worse right now. These data are from San Francisco. The blue lines are methamphetamine deaths. And the yellow line is methamphetamine without opioid. So you can see that yellow line. It went up from since 2009, and it's actually not gone up that much in recent years. So these are methamphetamines without opioids. So we're not seeing a huge spike in methamphetamines without opioids. That big increase in methamphetamine deaths in the last couple of years is frankly fentanyl driven. And we've gone from about 37% of fentanyl deaths involving an opioid to 3/4 involving fentanyl. So a huge increase. And I will talk about, and we can debate and discuss, and I hope you'll have questions about, how do we determine that a fentanyl death was also due to methamphetamine? It's an honest question. And I know I'm talking about methamphetamine, but I cannot talk about stimulants. I lump them together sometimes. The data are really similar for cocaine. We went from about half of the cocaine deaths involving opioids to 3/4 involving fentanyl in San Francisco. And I think it's a common theme around the country that fentanyl deaths are involving a lot of stimulants, which kind of brings you to, why are people using stimulants? I think we all know that, one of the drivers for people using fentanyl to use stimulants is the intensely sedating effects of fentanyl. So stimulants help you kind of stay awake and get things done. In addition, there are multiple other reasons people use stimulants. Some of our work in San Francisco has demonstrated, and actually it goes historically, that there's probably for some people who are losing access to prescribed opioids, report that they're using stimulants for pain self-management. As a physician, I think on the gut response is, oh yeah, that's a load of crap. They just want to get high. But when you actually look into the data, there actually is a long history of stimulants being effective in pain management, from the Brompton cocktail in the 50s to research in the 70s and 80s that showed that adding an amphetamine to morphine post-op enhanced pain management and radically decreased the amount of opioids needed. That's not to say that we should be prescribing people stimulants to manage their pain, but it helps to understand why people are driven to use substances, because it changes how you're going to respond to it and how you're going to manage it. So there's a bunch of questions that I have, and I'm going to try to give you some answers. Some of these I think are pretty solid. Some are based on data. Some are a little bit speculative. And I can't answer all of these completely, but these are some of the key questions that drive me. First, what is an overdose? I'm going to argue that we know pretty well what an overdose is for opioids, but that we don't really know what an overdose is for stimulants. The next is, our stimulant or methamphetamine fentanyl deaths fundamentally fentanyl deaths? Are these really fentanyl deaths, and the stimulants are essentially a bystander? Maybe they're a marker of riskier substance use, but are the stimulants really contributing to these sort of meth fentanyl deaths, or are they really just fentanyl deaths? And then the next is, how many of these stimulant fentanyl deaths are unintentional exposure to fentanyl? And then, what is the role of naloxone, and what is the role of other things that we're doing? There's some controversy around things like that with fentanyl. All right, so pathophysiology. You think that opioid overdose is really simple and really basic, right? I actually think it's really fascinating, because it's not just about, you take opioids, you stop breathing. The opioids don't actually make you stop breathing. They numb the receptor in your carotid artery that allows you to sense rising carbon dioxide levels. So the reason if you hold your breath right now, the reason you're going to want to breathe in 10, 20, 30 seconds is because your carbon dioxide levels are going up. And you want your CO2 levels, your venous CO2 levels around 40. If they start going above that, your body wants to breathe. And so in general, you hit 45, you kind of want to breathe. You hit 50, you really want to breathe. By the time you get up to like 80 or 90, the carbon dioxide itself has narked out your brain, and you're not really responsive anymore. So when opioids numb that receptor, if they numb it enough, you're not breathing. You get up to 80, 90, and it's not until then that you're up to like 80 or 90 CO2 that your oxygen levels actually start to decline, because the hemoglobin in your blood holds this huge reserve of oxygen that it can allow to dissolve into your blood. So your O2 levels don't start to drop for a while. And we know basically, that oxygen, that CO2 levels going up for a while. And maybe 15, 30 minutes into it, your oxygen levels are starting to drop. That really makes you want to breathe, but your CO2 levels are so high at this point that you're too narked out from CO2, notwithstanding the opioids, to start breathing. And so you're non-responsive at that point. And then, only then, do you start to reach that risk of cardiac arrest. You really got to get hypoxic before you're going to hit cardiac arrest. So in general, when somebody overdoses on heroin, they don't stop breathing. They drop to 2, 3, 4, 5 times a minute breathing. So they're still breathing. They're still transferring some, but their CO2 levels are rising. And then, eventually they stop breathing and they hit cardiac arrest. And cardiac arrest is what kills you. I think as an intern, when I was filling out death certificates, I'd always put cardiac arrest. I mean, obviously, but it doesn't really give you much information. Cardiac arrest is what kills all of us eventually. So the issue with fentanyl is the speed with which it works. It's highly lipophilic. It crosses into the brain really fast. Its effects are super fast. And instead of having 30 minutes to an hour plus to respond to an overdose, we've got 5, 10, 15 minutes before somebody hits cardiac arrest. And, with heroin, you don't see a needle in the arm after somebody injects and overdoses because they have time to take it out and et cetera, et cetera. With fentanyl, you do. We saw that, from the 2015-14 data from Massachusetts, the ethnographic data around fentanyl overdose. So people's breathing, it drops to 0 or close to 0 really fast, and they reach that point where they're in cardiac arrest really quick. Carl Spohr, a fantastic emergency physician in San Francisco, he used to say that By the time a heroin overdose reaches cardiac arrest, there's not a lot of point in reviving them because the likelihood is they've been hypoxic for so long, if they're revivable, they're going to be essentially brain dead. With fentanyl, it's probably not the case. In fentanyl, it happens so fast. If you can revive them, they've probably only been hypoxic for 5 minutes. So there might be a greater role for more rapid advanced medical response in fentanyl than there was for heroin. Okay, stimulants, totally different. They don't stop you from breathing, right? Maybe you breathe faster. And we also know that, I'll get into that in a minute, I'm going to make an argument. I'm going to go through some data, and hopefully, I'm hoping that you'll walk out of here thinking about this as a new construct for stimulant toxicity, or you'll come up with your own construct for stimulant toxicity, because this is a whole new world to think about. I think there's two major pathways, and I'm generalizing to lump them into two pathways to stimulant toxicity. One is vascular, the other is psychiatric or neuropsychiatric. And I'll go into emergency department presentations, and I'll go into causes of death. But very briefly, for the emergency department presentations, people might come in with chest pain. They might come in with a cardiac arrest, et cetera. They might come in with a stroke. Those are all, to me, vascular, cardiovascular, cerebrovascular. Maybe they have rhabdomyolysis. Maybe it's a renovascular or causes of presenting to the emergency department. And that's probably what accounts for most of these stimulant, quote, overdose deaths. Psychiatric presentations to the emergency room are mostly thought about as psychotic episodes, or what an ED doc would call agitated delirium. And also probably some physical trauma, maybe suicide attempts, things like that. And the causes of death in this category, we don't count at all. These aren't overdose deaths at all. But when you dive into the data, you can see people who use stimulants have much higher rates of suicide, of homicide, of other traumatic causes of death. And but we don't count that in the realm of stimulant toxicity. I would argue that we should. So stimulant emergency departments, admissions. So about half, for methamphetamine, about half are psychiatric issues, about a quarter are cardiovascular. For cocaine, it's equally split, about a third and a third. And then you've got, depending on the study, 20 to 50% of these presentations for stimulants are related to trauma, other injury-related presentations. And when we look at cause of death, this is global data on stimulant-related mortality among people who use stimulants. And there's a higher rate, 5-fold higher rate of cardiovascular disease resulting in mortality, 5-fold higher rate of accidental injury, which would be that traumatic category, 12-fold higher rate of homicide and suicide, 25-fold higher rate of drug poisonings. So what I'm going to argue is that those drug poisonings, many of them, some of them are opioid related also, but excluding the opioid related ones, the ones that are just related to stimulants are probably connected to that cardiovascular disease category. And these accidental injuries, these homicides, these suicides, not all of them, but some of them are related to the psychiatric toxicity category of stimulant related toxicity. So going back to that question, how does a medical examiner determine that a death was due to acute stimulant toxicity? So going back to opioids, when you talk about opioid toxicity, a classic overdose death, the medical examiner interviews somebody, they see the death scene, they see a syringe nearby with some black tar-like substance in it. They talk to people who were like, yeah, he used some drugs last night. He was snoring all night, and he was dead when we woke him up in the morning. That's classic. You know what happened there. You know this person used an opioid. They weren't breathing sufficiently. They went into cardiac arrest overnight, and they died. With stimulants, it's way more vague, and we don't know most of the circumstances where this is happening. And if you think that most of these are cardiovascular in nature, you know, a medical examiner can't always tell. So we're gonna do a little experiment here. My daughter loves the Sunday newspaper for where you match one picture to another to see what the difference is. So I want you to take a look at these two pictures and tell me what the difference is. One of them is from somebody who died from a fatal ventricular arrhythmia. The other one is someone who died but didn't have a fatal ventricular arrhythmia. So can you spot the difference? Neither can I. So you know, medical examiners can't tell, they're the identical picture, of course. Medical examiners can't tell the difference. Like, you can't actually see that somebody had a fatal ventricular arrhythmia. Sometimes you get lucky and they had a heart attack and you can see an area of fibrotic tissue, or, you know, or they have a otherwise abnormal heart. It's the walls are enlarged, or it's dilated and loose and floppy. You know, there's lots of things that can be wrong with the heart, and they do see a lot of problems with hearts on autopsies among people who died from a stimulant-related death. But you can't always see that. Most of the time you actually can't see. And you can't see that they went into a fatal ventricular arrhythmia. So they end up looking at the death scene, the history, the medical record, the toxicology results, the autopsy results, and if there's a bunch of stimulants and no other obvious cause of death, they attribute it to stimulants. It's not very satisfying, but it's the best we got. We did an analysis looking at additional causes of death among people who died from stimulants and opioids in San Francisco. And the medical examiner, when they put in a cause of death, they can put in multiple causes of death. They can put in, you know, acute opioid toxicity and sepsis. They can put in acute cerebral hemorrhage, a brain bleed, and acute methamphetamine toxicity. They can put in multiple causes of death in whatever order they want. So we include all the causes of death when we do an analysis. So we took 2,000 deaths and we coded their causes of death as in cardiac, cerebrovascular, which is generally a brain bleed or a stroke, and all the other various causes of death that they had. Most deaths only had acute drug toxicity. Among those, but for stimulants, about 8% also had a cardiac cause of death compared to 2% for opioids. And 13% had a stroke, essentially, compared to almost none for opioid deaths. And the cardiac causes of death were more common for cocaine deaths compared to meth, and the strokes were more common for meth compared to cocaine. The simple picture I used to put up when I gave this talk was, or when I gave talks like this 20 years ago, was meth mucks your brain, cocaine mucks your heart, heroin mucks your lungs. That was really simple. I've gotten a little more sophisticated since then. All right, on to the next question, or kind of continuing that thread. Stimulant and fentanyl deaths, are they really just fentanyl deaths? So the first thing to think about is toxidromes. So if you're coming to an emergency department, are we concerned about a stimulant fentanyl, a methamphetamine fentanyl presentation in the emergency department? I get contacted by people all around the country, and you know, there's been efforts to develop therapeutics that reversal agents for methamphetamine, or reversal agents that reverse methamphetamine and fentanyl at the same time. You know, there is no upper downer toxidrome. Nobody shows up at the emergency department freaking out and not breathing. You know. So there's no toxidrome. There's no thing that we're treating that's stimulants, you know, methamphetamine and fentanyl causing a toxidrome. So that would argue that these deaths are either driven by methamphetamine or they're driven by fentanyl, as opposed to both. In addition, you know, that last slide I showed, The deaths that, in that last slide I showed, I neglected to mention that we lumped the stimulant opioid deaths. That study, I'm going to go back there actually for a moment. Sorry. In this study, we lumped the stimulant opioid deaths with the opioid deaths. This was done pre-fentanyl, so it doesn't involve fentanyl, but for other opioids, the stimulant opioid deaths looked exactly like the opioid deaths. They had the same demographics, they had the same other causes of death. So they really looked like the opioid deaths. And, you know, at least prior to fentanyl, I'm pretty convinced that a cocaine heroin death was usually a heroin overdose death. And the cocaine was a bystander, a marker of risky behavior, and not pharmacologically contributing to the death. Because we know that actually if you add stimulants to an opioid, you actually do have a lower risk of respiratory depression from the opioid. So pharmacologically, stimulants kind of prevent overdose. Behaviorally, they almost certainly increase overdose risk. And the net is an increase in overdose risk. So the argument that this, you know, this hypothesis, which I'm still going to stick in that hypothesis category, it may not be right, is that fentanyl is really different from other opioids. It's structurally different, it behaves differently. Maybe it interacts with stimulants in a different way than other opioids do. So this argument, which I think, if I had to pick a side, I'd pick that these are fundamentally fentanyl deaths. But I don't know for sure because fentanyl is such a weird drug. So, all right, next question. Are stimulant deaths, are methamphetamine deaths really acute toxicity deaths? Or are they chronic diseases masquerading as an acute event? You know, more bad humor here. My wife and I really enjoy dressing up, and there, you know, the appearance, your underlying appearance is your chronic condition, and what you're wearing on top is acute event. So the idea here is you've got all this cardiovascular disease. You know, if you're 17 years old and you're going to go and do some methamphetamine, it's really unlikely to kill you. Most methamphetamine deaths, even more so than opioid deaths. So the stimulant toxicity deaths are older because you need time to develop that cardiovascular disease that's going to kill you, or that psychiatric disease that's going to kill you. You don't usually end up with major comorbidities from stimulant use when you're a teenager. Even if you're using quite a bit of stimulants, it takes time to develop the chronic conditions that put you at risk for that fatal tachyarrhythmia. In contrast with fentanyl or other opioids, you can use it your first time when you're 17 years old and stop breathing and you're dead. The reason that the opioid deaths also tend to be older is because when you're 17, you're using it with 5 friends who can save you. When you're 45, you're using it by yourself in your hotel room and there's nobody there to help you. So the social isolation increases mortality with age. There's also some physical comorbidities that increase mortality, but I think social isolation is probably a major driver of that. So I would argue that most stimulant deaths are the result of chronic cumulative toxicity of stimulants over time. That would also mean that we're missing a lot of stimulant deaths because there's probably a lot of heart failure deaths out there, cardiac deaths out there that don't have stimulants on board, so they're not attributed to stimulants, but the cardiac disease itself was actually due to chronic stimulant use. I'm getting some head nods. I love it. I love being able to actually see people. All right. So what is the difference between other opioids and fentanyl? There's a great study from the Sydney injection facility where when you go into the Sydney, the supervised injection facility in Sydney, you say, you're at the front desk, you say, they ask you, what are you going to inject today? And you say, I'm going to inject oxycodone, heroin, fentanyl, say what you're going to inject. So, you know, it's not you have a pretty good idea. And there's not, or at least at this point in time, there wasn't illicitly manufactured fentanyl in Australia. So people had a pretty good idea when they were injecting fentanyl or oxycodone versus heroin. And the relative risk of having an overdose was fourfold higher if you walked in and said you were injecting heroin, and 9 times higher if you walked in and said you were injecting fentanyl compared to prescription opioid. So there's a much higher risk of having an overdose event when you're using fentanyl, even if you know you're using it. So on the West Coast, most people, at least in San Francisco, most people, we don't have a lot of counterfeit pills in San Francisco. So most people that are using fentanyl know they're using fentanyl because they can readily distinguish it from tar. We don't see a lot of fentanyl mixed with tar. Different on the East Coast, where all the opioids are mixed together into various powders of whatever color. But so even if you know that you're using fentanyl, your risk of an overdose event is 9 times higher than if you were injecting oxycodone. And then there's the risk of the other question I had was, what's the risk of death when you overdose on fentanyl compared to another opioid? These data are a little bit softer. We don't yet actually know the answer to that. This is a study of people who showed up at the emergency room after an overdose on different drugs, and it was the likelihood that they would need advanced respiratory support. So to be intubated or have BiPAP put on. So fentanyl overdoses were twice as likely to need advanced respiratory support when they showed up at the emergency room compared to other opioids. That's my best approximation to risk of death after an overdose event. It's not great, but it's the best I got. So, the question is, the question that I'm getting to is the role of naloxone. And there's a lot of controversy about naloxone for fentanyl, at least federally. And there's big efforts to come up with, higher dose naloxone. Should we just hit them with a gram of Narcan? Does Narcan not work at all? There's efforts to develop new reversal agents. I actually think the data don't support any of that. I think in the community data that we see is that naloxone works just as well for fentanyl as it does for heroin, as it did for heroin. And the old nasal Narcan we used to use with that crazy jerry-rigged atomizer thing, that doesn't work because it was too dilute. It was a really low dose anyway, but the intramuscular actually seems to work pretty well. And the thing that we're struggling with is the fact that naloxone doesn't reverse cardiac arrest. And in fact, it doesn't do anything in cardiac arrest. It just sits wherever you put it because the blood's not moving. You got to get the naloxone to the brain. This has led me personally to when, back in the old days, we used to argue that chest compressions were not necessary in overdose reversal. And, based on Dr. Carl Spohr's argument that if you've reached cardiac arrest from a heroin overdose, you might not want to be saved because you've been hypoxic for so long. That kind of made sense back then. But today, given that you can hit cardiac arrest so fast, I actually personally support chest compressions and teaching people chest compressions for an overdose. Rescue breathing is great as well if they're willing to do it, they're able to do it, they can do it correctly. Those are all big ifs. But I actually think chest compressions really do have a role in overdose response now, much more than they used to, because of the rapidity of progression to cardiac arrest and the lack of naloxone's effectiveness when you're in cardiac arrest. It's not going to do anything. So I took a model that I did a decade ago of the role of a mathematical model predicting the role of naloxone in overdose prevention. And I updated it to fentanyl. So what you can see here on the far left is that 0%. That's if it's all heroin, there's no fentanyl around. You'd expect to see, without any interventions, about 1% of people who inject heroin to die a year from overdose. With a really great naloxone program, which I would argue a place like San Francisco has, that maybe 80% of people at risk have access to naloxone in one form or another, you drop mortality by about 1/4. you get down to about 0.7% of people dying from overdose, from overdose in a given year. Yeah, I don't know, that might sound not compelling to you. It's really compelling to me. I mean, that's 25% of people not dying. They get to zero idea, I think is, I'm not sure if we can do that, but a 25% reduction in this context is huge. It meant in San Francisco, we went from probably about 185 to 125 deaths. I mean, that's a big deal. And as you transition to fentanyl, you get to about 4.1, just over 4% of people dying a year. That is a huge number, by the way. Absolutely bloody terrifying. And with a great naloxone program, it ends up being about 3.5%, which is, in terms of the absolute number of deaths you're preventing, it's a bigger number of deaths, but it's not 25%. It's more like 12, 13%, which is kind of demoralizing. And when you look at when you look at the numbers and you see that there's been, a fourfold increase, that's really demoralizing. Or if you have a great naloxone program, you might actually see a fivefold increase because your numbers were lower to start with and they went up a little more steeply. So it could look like in an area where you've got great overdose prevention programming, you've got a higher fold increase than an area that wasn't doing anything to prevent overdoses. So it's a little counterintuitive, but really important to recognize so that you're not kicking yourself that you're failing or that your interventions aren't working. Your interventions are working. They're preventing even more deaths than they were, but the numbers are just so much bigger. So this is both to kind of say, hey, we're in a crisis, it's a disaster, but also don't give up. What you're doing is working. It's just, you're working on a different scale and you can't get the same percentage benefits from the interventions. This is what it would look like if naloxone actually didn't work for fentanyl. If it works for heroin, but it doesn't work quite as well for fentanyl, you'd end up with an even steeper increase. What we saw in San Francisco is in the light green dots. So I think it was 2014, we had 5% fentanyl among our deaths. They line up pretty well with that naloxone, with that expected number of deaths in the setting of naloxone. The last dot on the right is with 91% of their deaths being from fentanyl. That's what we have in 2021. They were a little bit higher in 2020, and that was COVID. I think we all know there was a lot of social isolation and a higher number of deaths that are attributed to that. All right. Okay, I think this is one of my last questions here. How often is fentanyl unintentional in a stimulant and fentanyl related death? I don't know the answer to that. This was my cheap and easy way to try to get an idea as to what was going on. So what we did was we took stimulant and fentanyl and other opioid deaths, and we reviewed the medical charts of the decedents to see if there was any evidence of opioid use in their record. What we know from old data 20 years ago was that people who died from an opioid overdose, 85% of them had evidence of opioid use in their medical records. What we found was that for non-fentanyl opioids, 82% of the decedents had evidence of opioid use in their medical records. So it matches data from 20 years ago. That's always reaffirming to me. It's kind of exciting. And it didn't matter whether the death involved heroin alone or heroin and a stimulant or heroin and a benzo. It was all 82% pretty much across the board. For fentanyl deaths, it was much lower. It was 56% of stimulant fentanyl deaths, 65% of fentanyl only deaths, and 48% of stimulant only deaths that didn't involve an opioid had a history of opioid use. So lots of polydrug use, et cetera, but the proportion of the fentanyl deaths that had evidence of opioid use in the 3 years leading up to their death in their medical record was much lower than what we expected. And this could be for a few different reasons. Maybe they started using fentanyl really recently. Maybe, but to me, it raises the possibility, not the confirmation, but the possibility that a significant proportion of these deaths are unintentional fentanyl exposure. And I played with these numbers a little bit and came up with the estimate that it could be as high as 25%, could be as much as a quarter of our fentanyl deaths. And in San Francisco, we have somewhere in the vicinity of 500 fentanyl deaths in a year. So that's 125 deaths that could be unintentional exposure among people intending to use a stimulant. That's a really, if we could trim 125 deaths off our numbers, that would be extraordinary. So to me, that's a really big deal. All right, so what are we gonna do? I tried to categorize some of the interventions that I think about for opioids and for stimulants. So pharmacologic category. So we've got a great reversal agent for opioids, naloxone. We don't really have a specific reversal agent for stimulants. We've got benzodiazepines, which work clinically, and antipsychotics, which help. I don't know if we really need a reversal agent for stimulants. For use disorder treatment, we've got bupe, we've got methadone, we've got extended release naltrexone. For stimulants, we don't have anything FDA approved. We've got multiple drugs in the that show some benefit. Mirtazapine, bupropion, conceivably bupropion plus extended release naltrexone, and then, some of the amphetamine type stimulants have shown some benefit. The most important thing though is, I think, if this is a chronic condition, is recognizing that any reduction in use is a win. And all my studies, I do tons of studies on methamphetamine, meds for methamphetamine use reduction. And all those studies are, our outcome is whether your urine's positive or negative for meth. So I'm not measuring whether or not you're using a half a bag instead of a bag. I'm measuring whether you're using or you're not. And it's a real failure of our research. I say that as somebody who lives off this research, right? But it is, it's a real failure in the research. We haven't had the technology. I have some ideas, but we're still nascent in this technology and this idea of being able to measure reduced use. But if most of the toxicity from stimulants, which is what I argue we should be focused on, is reducing the toxicity of the drugs people are using. Stopping using is a great solution, but if we can't get people to stop using, how can we reduce the toxicity? Use reduction should really be at the top of our list. Any reduction in use is, gives people a little bit more time. I think about my dad, he had diabetes and he never got his A1C under control. His donut habit was uncontrollable. And he lived an extra 15 years compared to his dad because of ACE inhibitors, statins, aspirin, and clinical care. So I always think about it with somebody who, if I can't help you get your drug use under control, if I can't help you get your donut habit under control, what can I do that gives you an extra decade? So behavioral, we have for opioids, there's overdose prevention plans. I had a study of called Reboot. It was an overdose prevention intervention among people who already had naloxone, and we showed that it reduced overdose events by 80%. We're repeating that study, and we'll have data on that in a year. But in general, I think it's worth sitting down, talking with people. If you have the time to sit down and talk with them, come up with an overdose prevention plan for them, because fundamentally that's what my behavioral intervention was about. Really, it's developing, leveraging their experience and what they've seen already in their own life to help them develop a plan to try to prevent overdoses from occurring. Because the bystander response approach, we got a quarter of as much time to make that work. We don't have the hour, we've got 10 minutes to make a bystander response plan work. So people need plans to prevent that from happening in the first place. So it's worth putting the time and energy into that. For stimulants, contingency management, CMS funding, yay, it's awesome. It's really exciting. I know there's hiccups rolling it out, but I'm really excited about that and expanding that. In the healthcare world, the thing I want to focus on is for stimulants, it's cardiac disease prevention. And as a physician, every patient I see, I'll enter them into a cardiac risk score and get their risk score. And based on that risk score and some lab values, I may prescribe a statin or aspirin or whatever medications I'm going to prescribe. Stimulants are not in that risk score. So you could have been using a ton of methamphetamine for 20 years, and based on my evaluation, you have no elevated cardiac risk. It doesn't make any sense. So I'm not going to put you on a statin. You know, your cholesterol's 200, but your cardiac risk is 1.7% based on the Framingham risk score. So you're not going on a statin. Whereas the reality is your cardiac risk is 20%, and I should absolutely have you on a statin. But stimulants, you know, nobody in Framingham, Massachusetts in the 60s and 70s or not enough people were using stimulants. So it's not in any of our data. It's not in any of our metrics. It's a huge problem. And there's this long time myth that beta blockers, which are super effective at preventing heart attacks and cardiac and rhythm issues among people who have coronary artery disease, there's this long held myth that you can't use them if somebody's using stimulants. That has been disproven again and again and again and again, but it still exists in the medical world, and most doctors won't start people on beta blockers, and it is a crime. Community-wise, safe spaces, you know, so we don't have a law that gives us safe consumption spaces. We can create other safe spaces because, you know, the truth is people need a place they can be when they're high, especially in places like San Francisco. And, you know, whether it's a drop-in space, a safe consumption space, a sobering space, just spaces for people to be so they're not alone. Safe supply, that's another thing. You know, Canada's way ahead of us. They've got morphine in vending machines. We're not anywhere near there. So we're doing what we can. The closest we have for safe supply for stimulants is the amphetamine type stimulants, dextroamphetamine, methylphenidate. The issue with those, one of the big issues, besides that it's not technically legal to use it for stimulant use disorder, you can use it if they have comorbid ADHD, but not for just stimulant use disorder. The other issue is that there's hypertension. If you have cardiovascular disease already, these things, as an internist, I can't use these if you've already got cardiovascular disease, because I could cause more cardiovascular disease. Drug checking programs, I still don't know exactly how they work, how they change behavior, but I think it's important, and I think they're really valuable. Fentanyl test strips, it's great. They cross-react with methamphetamine. It's a big problem. Hopefully a better technology soon. And then I can't not say something about structural determinants of health, and that is our social determinants of health, and in particular, structural racism. We're not gonna, I love harm reduction. I've been doing it my entire life. We're not gonna fix the huge inequity between the huge inequity in drug-related morbidity and mortality without addressing the larger issues of structural racism and social determinants of health. It's just not going to do it. So I feel like it's most of what I do is secondary, tertiary prevention. You got to get more into the primary prevention area for that. All right, one thing on antipsychotics, a little novel program that San Francisco started earlier this year is what maybe is the next naloxone overdose prevention kit in response to psychiatric toxicity of stimulants. We are giving out what we're calling chill packs, which is packs of a small number of tablets of sublingual dissolving olanzapine, which is an antipsychotic medication that helps to reverse methamphetamine-induced psychosis. We are giving it out from psychiatric emergency services to people who come in with methamphetamine psychosis. We're planning on hopefully expanding it more broadly than that. It's controversial. And, people are to take it when they're feeling effects, psychiatric effects related to methamphetamine. It's got low side effects, minimal drug-drug interactions, pretty safe in that regard. We don't really know how people are going to use it. Maybe they're going to use it to come down from stimulant, from a meth high, instead of taking a Xanny they bought on the street that might be fentanyl. Maybe they're going to use it to actually deal with a methamphetamine psychosis so they don't end up arrested or in psych emergency services. We don't know yet. So it's really exploratory, but to me it's exciting because it actually tries to address a toxicity that nobody has actually directly tried to address in a sort of secondary prevention fashion. And when I think about the controversial nature of this, I go back and I think about the fact that 20 years ago, naloxone was extremely controversial, extremely controversial. If you weren't around then, if you weren't part of this then, you don't remember that, giving out naloxone was, it was illegal, and it was really crazy 20 some years ago. So very briefly, I realized that I'm heading into break time. I did start late, but I wanted to try to finish before break because I'm a fan of breaks. Okay. Death from stimulant toxicity has increased. Mostly it's related to fentanyl, but it did increase for methamphetamine on its own, at least. The deaths are probably mostly cardiac events and strokes. Maybe some psychiatric, maybe there's more than we know, psychiatric related suicides, homicides, and violent trauma. Most of these deaths are from chronic cumulative exposure. You might have a 17-year-old who has an occult cardiac condition that dies when they use methamphetamine. But most of the time, this is chronic cumulative exposure. I think stimulants are a marker of riskier opioid use behavior, and that's why you see such a high rate of stimulant opioid deaths. But maybe fentanyl interacts differently. I don't know. I doubt it, but it's possible. And I can't rule that out. It's such a different opioid. The increased death we see from fentanyl, like 4-fold increased death, is because you're more likely to overdose when you use fentanyl. And so, you overdose, I reverse you with naloxone. Let's say you were using heroin, you're going to overdose twice in 5 years. You're using fentanyl, you're going to overdose 8 times. You're going to overdose not 8 times, but probably 20 times in 5 years. So I'm going to reverse you with naloxone many of those times, but one of those times I'm not going to get there in time. And so your death is 4 times higher. And there is a limited window for bystander response. So any of our bystander interventions have issues, and we have to be really innovative. I think that there's a meaningful proportion of stimulant deaths that are due to unintentional fentanyl exposure. Most people we've interviewed in San Francisco who use drugs have said that, yeah, they know that they use both. So I'm not getting that from interviews. I'm just getting it from looking at the people who actually died, because they're different than the people who are still living. And I think there's a good number of unintentional exposure deaths. We've got some interventions slowly emerging around stimulants, contingency management. We've got several medications we talked about, and other innovative strategies like cardiac preventive care. Really aggressive cardiac preventive care. If you've got people that are using stimulants, really got to think about what we're going to do to try to prevent them from dying from their stimulant exposure. The first assist packs or chill packs, the idea of giving people, as needed olanzapine to help self-manage this, and thinking about any reduction in use as a valid treatment goal. Safe spaces, drug checking. That's all I have. I'm happy to take a few questions.
Is this on? Yeah, awesome. I really want to thank Dr. Coffin. Can we give him another round of applause, please? Thank you. Thank you so much. You guys all are mostly likely all of you are going to have another couple of years to implement this information, which is very exciting. And also, I think I'm the person that told him he was really morbid in his presentations. So I probably depressed him from the, out of the gate, but this is really important information. We love evidence-based material. He gave us solid information about what's happening with the methamphetamine that is affecting our families, our kids, our adults, really good, important information about opioids and fentanyl. So I am excited that you're going to be able to implement it. So if we have a couple of questions, I hope you will look back at the PowerPoint that he has, because it's a lot to think about it. I've been thinking about it for the last 4 months since I heard it the first time. Yes. Let me come run to you. Sorry. Here we are. Okay, your question?
Hi, I'm Rosemary, the substance use navigator from San Joaquin General, and you referenced the chill pack, the olanzapine. You said small doses. How small?
So I believe they are 5 milligram sublingual tablets, and we give a small number. So we give them like 5. Yeah, it's, this is totally innovative. I don't think it's ever been done before. I think some people like Andrew Herring at Highland Hospital has given antipsychotics for people kind of like this. So I might not be quite as novel as I think, but doing it as a program, it's a novel construct.
Thank you. We have another question.
Well, just a comment. My name is Danny Contreras from County Santa Cruz. Do you have that brochure that you could give us?
I don't have the actual brochure. I don't know if it's available online or not. It is in that first page is in the slides. There's a second page to the brochure. I can try to share it.
We will figure that out. And also, while Danny Contreras has just announced himself, I just want to say that the title of our conference, Making a Transformation, is Danny's idea. Shout out to Danny. Woohoo, woohoo. And it was all about how you turn from a, caterpillar to a butterfly and you make a transformation. So there we are. It was Danny's. So thank you, Danny. And yes.
Hi, I'm Rebecca Couch, substance use specialist from Communicare Health Centers in Woodland. My question is, do you anticipate a timeline before chill packs would be made available to mental health response law enforcement?
Great question.
No. I mean, right now we've probably given out maybe 100 or a couple hundred from psych emergency services. So that will, our next step is probably the outreach teams, the street outreach teams. So, it's so novel. We don't know how it's, we want to get a little bit of data on what's actually being done with the packs. Effectiveness data is way down the road, but what's actually being done with the packs, we need some basic data before we can think about really deploying it wide scale.